So I moved to Hawaii about 7 months ago, and when I miss my colleagues and friends in Los Angeles, I think about how lucky I am to live in paradise. This is a picture of Lanikai Beach in Oahu. I want to say that the information and photos are taken directly from the BCSC. This is meant to be a synopsis of that. I don't intend for this to be my own information. I also borrowed some diagrams from David C.'s oculoplastics text. So we're going to jump in with facial anatomy, and a few terms in facial anatomy that are often used are the SMAS, SOOF, and ROOF. And SMAS refers to the superficial musculoaponeurotic system, and this really facilitates facial expression and is important in rejuvenation procedures. The SOOF refers to suborbicularis oculi fat, which overlies the maxillary and zygomatic periosteum. And the ROOF is the retroorbicularis oculi fat, which is deep to the brow. The SMAS, as I mentioned, it facilitates facial expression, and it consists of the superficial facial fascia, the platysma, the zygomaticus major, zygomaticus minor, and the orbicularis oculi. I struggled a little bit in how to mention the facial nerve, because you could easily do an hour-long lecture on the facial nerve, and it seems unjust to try to summarize it in one slide. But I think understanding the course of the facial nerve in the face is important for various procedures we do, including temporal artery biopsies, as well as brow procedures. And just recalling that the branches of the facial nerve are the temporal, this is going from superior to inferior, the temporal, zygomatic, buccal, marginal mandibular, and cervical. So jumping into the eyelids, the orbicularis oculi is the main protractor of the eyelid. And it has, oh, this isn't showing up here. So it has a pretarsal, preseptal, and orbital portion. And the Horner's tensor tarsi is the deep head of the pretarsal muscle. This encircles both canaliculi to facilitate tear drainage. So the orbicularis is important not only in eyelid closure and in blink, but also in tear physiology. The orbital septum serves as a barrier between the orbit and the eyelid to limit the spread of infection and hemorrhage. It arises from the periosteum over the orbital rim at the arcus marginalis. And in the upper lid, it then fuses with the levator aponeurosis. In the lower lid, it fuses with the capsulopalpebral fascia. So this is sort of a busy sagittal section of the eyelid, but it's really important to understand the structures of the eyelid working anterior to posteriorly in terms of surgery or trauma. The upper eyelid retractors are the levator palpebrae superioris and the superior tarsal muscle. The levator originates from the periorbita of the lesser wing of the sphenoid and runs about 40 millimeters in length. The superior tarsal muscle, which we know is Mueller's muscle, is innervated sympathetically. It originates at the undersurface of the levator, and it only provides about 2 millimeters of elevation, which is an important point when considering what types of procedures one can use to correct blepharotosis. The superior transverse ligament, or Whitnell's ligament, which is structure B in this picture here, provides suspensory support for the upper lid and the superior orbital tissues. It also acts as a fulcrum for the levator because it transfers the vector from an anterior-posterior direction to a superior-inferior direction. And its analog in the lower lid is Lockwood's ligament. The lower eyelid has the capsulopalpebral head, which fuses with the sheath of the inferior oblique, and it divides as it goes around the inferior oblique, and then it forms Lockwood's suspensory ligament, and then anterior to that is the capsulopalpebral fascia, which is analogous to the levator. And then just posterior to that is the inferior tarsal muscle, which is analogous to Mueller's. The tarsus consists of dense plates of connective tissue that give structure to the eyelid. And in floppy eyelid syndrome, you have a marked decrease in elastin fibers. I mention that only because I've seen it as a test question in the past. The upper lid tarsus is about 10 to 12 millimeters at its greatest height vertically. The lower lid tarsus is about 4 millimeters, and that's relevant in reconstructive procedures, as I'll discuss a little bit later. It's about 1 millimeter thick, and it's associated with the marginal arterial arcade, which lies 2 millimeters superior to the lid margin, anterior to the tarsus. The marginal arterial arcade is not to be confused with the peripheral arterial arcade, which is superior to tarsus between levator and molars. Conjunctiva is non-keratinizing squamous epithelium that contains goblet cells, which secrete mucin, as well as the accessory lacrimal glands of Krauss and Wolfring. So looking at the eyelid margin and working our way posteriorly to anteriorly, the mucocutaneous junction lies posterior to the meibomian gland orifices, and then anterior to the meibomian gland orifices is the muscle of Riolan, which is the gray line, and this is really an isolated section of pretarsal orbicularis muscle. The margin, the horizontal palpebral fissure is about 30 millimeters in length. Just one note on the meibomian glands, that both the meibomian glands and the eyelashes differentiate during the second month of gestation from a common pilosebaceous unit, and that gives some understanding to distichiasis, because in acquired distichiasis, you have a lash follicle that develops from the meibomian gland following trauma or chronic irritation. In congenital distichiasis, there's an extra row of lashes arising from the meibomian gland orifices, and this sort of makes sense understanding their origin. The vascular supply of the eyelid, the arterial supply is from two sources, the internal carotid artery via the ophthalmic artery, and then which gives rise to the supraorbital and lacrimal branches, and the external carotid artery via the arteries of the face, namely the angular and temporal arteries. Venous drainage pretarsally occurs medially via the angular vein in the face, laterally via the superficial temporal vein, and posttarsally via orbital veins and deeper branches of the anterior facial vein and pterygoid plexus. Lymphatic drainage is a little bit nebulous, but generally medially, the medial eyelids drain to the submandibular lymph nodes, and the lateral lids drain to the superficial preauricular nodes, and then from there to the deeper cervical nodes. Sensory nerve supply is provided to the forehead and lateral periocular region via the supraorbital nerve, which is V1, and to the lower eyelid and cheek via the maxillary nerve, which is V2. And then motor nerve supply, as we know, is cranial nerves 3 and 7, as well as sympathetic nerves. So to review some eyelid disorders, starting with congenital anomalies, there's blepharophimosis syndrome, which we'll talk a little bit more about, and then congenital forms of ptosis, ectropion, and tropion, distichiasis, coloboma, congenital eyelid lesions, and cryptophthalmos. So among the congenital anomalies, ankyloblepharon is closure of the eyelids, either partial or complete, by these webs of skin. This is epiblepharon, which the lower lid pretarsal muscle and skin ride above the eyelid margin. The eyelid margin's in a normal position, but they ride above and push the cilia upward and cause often irritation of the cornea. In epicanthus, there's this medial fold of skin, and in uriblepharon, there's a widening of the horizontal palpebral fissure. There are 4 types of epicanthus, and epicanthus tarsalis is most frequently associated with the Asian eyelid. Epicanthus inversus is associated with blepharophimosis syndrome, and most of these forms resolve with normal growth of the facial bones, although epicanthus inversus typically requires surgery. So blepharophimosis syndrome is an autosomal dominant syndrome in which the patient has telecanthus, or a widened intercanthal distance, epicanthus inversus, and severe ptosis. They may also have lower lid ectropion, a poorly developed nasal bridge, and hypoplasia of the superior orbital rims. And reconstruction has to take place in multiple stages for these patients. Congenital ectropion is rarely an isolated condition. More often it's associated with blepharophimosis or even ichthyosis, and it's really characterized by vertical insufficiency of the anterior lamella. If it's mild, then treatment isn't really necessary or can just be lubrication. But if it's severe and symptomatic, then there needs to be tightening of the lateral canthal tendon and vertical lengthening of the anterior lamella with a skin graft to sort of lengthen that lamella. A congenital coloboma is an isolated anomaly when it occurs in the medial upper lid. It's not part of any other syndrome, and this can often be reconstructed primarily. Capillary hemangiomas most often appear over the first weeks or months of life rather than directly at birth, and of course, if they're amblyogenic, need to be treated. Cryptophthalmos is characterized by partial or complete absence of the following adnexal structures: the eyebrow, palpebral fissure, eyelashes, and conjunctiva. And these partially developed adnexa are fused to the globe. This is a very rare condition. So moving on to acquired eyelid disorders, chalazion is an inflammation involving chronic lipogranulomatosis inflammation from the meibomian glands. Hordeolum is typically infectious from the glands of Zeiss if it's external, or from the meibomian glands if it's internal. Floppy eyelid syndrome, as we mentioned earlier, shows a marked decrease in elastin fibers in the tarsus. And then there's eyelid imbrication syndrome. This is similar to floppy eyelid, but the tarsal plate is normal, and the upper lid does not easily avert. So what happens is that there's horizontal laxity of the upper lid that interferes with normal upper lid apposition against the globe during blink, and then the upper lid overrides the lower lid margin during closure. And so the lower lid margin irritates the conjunctival surface of the upper lid, causing a chronic conjunctivitis and keratinization. And this leads to corneal surface irritation and tear film abnormalities. The treatment of this is either lubrication or horizontal tightening of the upper lid. Epithelial proliferations include seborrheic keratosis, verruca vulgaris, and cutaneous horns, and these need to be excised at the dermal-epidermal junction. Benign epithelial cysts include epidermal inclusion cysts, which arise from a hair follicle and are filled with keratin, pilar cysts or tricholemal cysts, which are most commonly found in the eyebrows, molluscum contagiosum, which may have an associated follicular conjunctivitis, and xanthelasmas, which are lipid-laden macrophages in the superficial dermis and subdermal tissues. And so typically the skin overlying needs to be removed as well, and recurrent xanthelasmas can, if they're recurrently excised, can lead to ectropion. So there's something to be conscious of. Benign adnexal tumors include lesions of oil gland origin. We talked about chalazion and hordeolum. And then there's sebaceous hyperplasia, which is multiple small yellow papules that may have central umbilication. Sebaceous adenoma, which is a yellowish papule that may mimic a basal cell carcinoma or seborrheic keratosis. And just something to keep in mind in patients with sebaceous adenomas is Muir-Torre syndrome, which is a rare autosomal dominant condition that consists of a visceral malignancy, most common colorectal, as well as sebaceous adenomas. And it's just something to consider if you see a patient with multiple sebaceous gland adenomas. Tumors of eccrine sweat gland origin. Eccrine sweat glands are located throughout the body and important in thermal regulation, and they include these various benign tumors, including an eccrine hydrocystoma and a pleomorphic adenoma of the lid, which is histologically identical to a pleomorphic adenoma of the lacrimal gland. These need to be surgically excised. Tumors of apocrine sweat gland origin arise from the glands of mole that are associated with eyelash follicles and include an apocrine hydrocystoma and cylindroma, and they are also treated with surgical excision. And then there are tumors of hair follicle origin, which include tricholemoma and pilomatrixoma, which can very rarely have some malignant potential. Pilomatrixomas are usually in the eyebrow and the upper lid, and they also need to be completely surgically excised. Moving on to benign melanocytic lesions, there are nevi, which we'll talk about a little bit more. Lentigo simplex are flat pigmented spots that are not related to sun exposure, but they may be associated with Poitz-Jeghers syndrome, which is characterized by multiple polyps in the GI tract and carries an increased risk of both GI and non-GI cancer. Solar lentigo is similar appearing, but is associated with sun exposure. A blue nevus has extremely low malignant potential and dermal melanocytosis. Nevus cells are incompletely differentiated melanocytes that begin to appear, and nevi begin to appear during childhood. They often demonstrate increased pigmentation in puberty, and they evolve during life through 3 stages. Initially, they're junctional, so they're located at the epidermal junction, and then they become compound, where they extend up into the dermis and down into the dermis. And lastly, the dermal phase consists of involution of the epidermal component with persistence of the dermal component. And pigmentation is lost as the epidermal component recedes. And so nevi on the eyelid margin actually often look non-pigmented. Malignant transformation may rarely occur. The nevus of Oda is a congenital blue nevus of periocular skin, and about 5% of these are bilateral. And it's associated with oculodermal melanocytosis, in which pigmentation also appears on the sclera and uvea. And as was mentioned yesterday, this carries an increased risk of uveal melanoma. Premalignant epidermal lesions include actinic keratosis, which carries a risk of transformation to squamous cell carcinoma. Squamous cell carcinoma in situ of the skin, 5% of those may progress to vertically invasive squamous cell carcinoma, and so they should be completely excised. Keratoacanthoma is a lesion that exhibits rapid growth and may involute spontaneously. And there is some debate as to whether this is really on part of a spectrum of squamous cell carcinoma, and so complete excision is indicated for these as well. A premalignant melanocytic lesion is lentigo maligna. This is a flat, irregularly shaped, and unevenly pigmented lesion that slowly enlarges. It may progress to invasive melanoma, and when it's on the eyelid, it may extend to the conjunctival surface, at which time it appears identical to PAM. So moving on to malignant eyelid tumors. Basal cell carcinoma is most commonly located on the lower eyelid margin and near the medial canthus. Risk factors include patients who are fair-skinned and of English, Irish, Scottish, or Scandinavian ancestry, and cigarette smoking is also a risk factor for these patients. Just something to keep in mind with basal cell carcinomas is the basal cell nevus syndrome, also called Gorlin syndrome, which is an autosomal dominant condition, and if you have a patient with multiple basal cell carcinomas prior to their age of their mid-30s, about 35, this is just something to consider. Xeroderma pigmentosum is also a condition, a rare condition. It's autosomal recessive, in which patients can have multiple basal cell or squamous cell carcinomas at a very young age, in their mid-20s. So this is a diagram of a nodular basal cell carcinoma with these pearly elevated margins and a central ulcerated area with telangiectatic vessels. There's lash loss, and it's not a great picture, but this is taken from the BCSC, and these are the ones that often appear on exams. And then here's a photograph of a morpheoform basal cell carcinoma. This is much less common than nodular, and the margins tend to be indistinct clinically, and this also needs complete excision. It's a more aggressive tumor than the nodular form. Just a couple notes on biopsy techniques. This demonstrates excisional biopsy. Here, there's a wedge biopsy, and we'll talk about how that's important in sebaceous cell carcinomas. This is incisional biopsy and a shave biopsy. So basal cell carcinomas in the medial canthus are more likely deeply infiltrative. It's something to think about when doing biopsies. And that if the basal cell carcinoma involves the lacrimal drainage system, it's important to wait until the patient is tumor-free for about 5 years, according to the book, before reconstruction. I think it's some people will say even at 1 year. And the reason is that you want to reduce the risk of seeding the tumor into CDCR tract. Definitive treatment really is, even if you do an excisional biopsy, is complete surgical excision with evaluation of the margins. A squamous cell carcinoma is an aggressive tumor that needs to be excised with a Mohs procedure or with wide margins and frozen sections in the operating room. It has metastatic potential, typically through lymphatic channels or direct extension along nerves. And that's a pretty devastating metastatic manner in which it spreads, and important to know about. Sebaceous adenocarcinoma arises from meibomian glands in the tarsus or glands of Zeiss, as well as from sebaceous glands of the caruncle, eyebrow, or facial skin. It's more common in the upper lid in contrast to basal cell and squamous cell, which are more commonly seen in the lower lid. And it also commonly originates from multiple locations. It has a yellow coloration from the lipid material in the neoplastic cells, and it's more commonly seen in older patients. So sebaceous adenocarcinoma may masquerade as benign lesions, and it's something to consider, for example, in patients with recurrent chalazions in the same area. But you want to look for malignant features as well. Again, any sort of bleeding or destruction of tissue or lash loss in that area. The tumor may extend over palpebral and bulbar conjunctiva, and this is where a full-thickness wedge biopsy is indicated because the origins of this tumor in the tarsal plate or the lid margin may be missed with just a superficial biopsy. Once the diagnosis is made from biopsy, wide excision with then map biopsies of the conjunctiva is indicated because, again, this tumor may have multiple different origins. And then lastly, malignant melanoma. There are 4 types of malignant melanoma. Lentigo-maligna melanoma is the invasive vertical malignant growth phase that occurs in about 10 to 20% of patients with lentigo maligna. It accounts for 90% of head and neck melanomas, and it consists of nodules within broader, flat, irregular macules. It usually occurs as secondary extension from the malar region when it's in the lid, and the pigmentation may progress over the margin onto the conjunctival surface. Nodular melanoma may be amelanotic, and its initial presentation is the vertical invasive growth phase, so it's likely already deep at the time of diagnosis. Superficial spreading melanoma and acrolentiginous melanoma are not typically seen on the eyelid. Acrolentiginous melanoma specifically refers to melanomas on the palms of the hands or the soles of the feet. It's really important with melanoma that the biopsy gauge the depth of the lesion. So, for example, the shave biopsy seen on the previous slide is not a good way to biopsy a lesion that's thought to possibly be melanoma because the depth of the lesion is an important prognostic indicator. Wide surgical excision once the diagnosis has been made from biopsy with examination of the lymph nodes, as well as referral to the oncologist for any metastatic potential is important. Kaposi sarcoma, which were seen widely in the AIDS crisis many years ago, is a reddish dermal mass, and these may regress with treatment of HIV. So I want to talk a little bit about eyelid reconstruction. The eyelid margin needs to be reconstructed with both the anterior and posterior lamella in mind. So the anterior lamella consists of skin and orbicularis, the posterior lamella, tarsus, and conjunctiva. So it's really important to replace both anterior and posterior lamella. And that can be done with a graft or a flap. A graft is tissue that's removed from the body, it's separated from its blood supply and moved to another location, whereas a flap is tissue that brings its own blood supply along with it. A graft placed on a graft has a high likelihood of failure. You really need to provide blood supply to the area. So in eyelid reconstruction, it's important to replace anterior and posterior lamella, and the anterior lamella can be replaced with an advancement flap where tissue is advanced forward or up, a rotational flap where tissue is rotated into the defect, or via a full-thickness skin graft. The posterior lamella can be replaced with tarsal flaps or grafts from another eyelid or with various tarsal substitutes. Other important principles in eyelid reconstruction are maximizing horizontal tension, minimizing vertical tension, and maintaining sufficient and anatomic canthal fixation. So what that means is when you're looking at an area in the eyelid, if there's a lesion from, for example, that's been biopsied, it's really important to close that lesion in a way that maintains the position of the eyelid and avoids any sort of ectropion by maximizing horizontal tension, minimizing vertical tension. Similarly, if you're going to create a defect, it's best to create one in such a way that simple closure avoids something that might cause an ectropion, and instead close it in such a way, or remove it in such a way that you can bring those wound edges together to maintain the eyelid position. Upper eyelid defects can be closed if they're less than a third of the eyelid. They can be closed primarily. If extra laxity needs to be harnessed, you can do a canthotomy to just bring these two edges together. If the defect is about a third to a half of the lid, then you can do a Tenzel semicircular flap to bring tissue across. If this is just showing a tarsal graft. If the defect is more than half of the lid, you can do a tarsal graft from another eyelid with a skin flap on top, a Cutler beard procedure, which we'll discuss more in an ensuing slide, or a lid sharing procedure from the lower lid. And lower eyelid defects, similar principles. The Tenzel semicircular flap is really nice because it can be performed for defects either in the upper or the lower lid. But a Hughes tarsoconjunctival flap rather than a Cutler beard procedure needs to be done for lower lid defects. So primary closure needs to involve apposition of the eyelid margin, typically with 2 or at least preferably 3 sutures, and then apposition of the tarsus and subcutaneous tissues. The semicircular flap, the shape of it is important for maintaining that canthal fixation that I mentioned earlier. And once the skin and orbicularis flap is liberated, then these two wound edges can be closed primarily, and the canthal defect is just closed directly. And again, this is for defects that range from a third to a half of the lid, and it can be used for either upper or lower eyelid defects. The Hughes tarsoconjunctival flap is for lower lid defects that are greater than 50% of the lid. This is a bridge flap that covers the pupil, and it's a staged procedure. So it's contraindicated in children who are at risk of occlusion amblyopia, in elderly patients at risk of falling, or in patients with poor vision in the fellow eye. And because the tarsus in the upper lid is about 10 millimeters in height, then you can borrow some of it for the lower lid. So you make your incision about 4 millimeters from the lid margin. This is an upper lid that's been everted over a Demar retractor. And you leave 4 millimeters of the tarsus for the upper lid, and you borrow the rest in a flap for the lower lid. And there's actually a really nice plane that's created between the tarsus and the orbicularis, and then this tissue is brought down and sutured to the tarsus in the lower lid, and a skin graft needs to be placed on top of that. The Cutler beard procedure doesn't work quite as well, but it's for upper eyelid defects that involve more than half of the lid. It's also a full thickness bridge flap, and it's also a staged procedure. So because the tarsus is much shorter in the lower lid, you can't borrow tarsus for the upper lid. You have to make your incision beneath that. So it's a full thickness incision, and then that tissue is brought under this bridge of tissue and sutured up into the defect. And then it's later cut, and the defect, the flap that has vascularized, is closed, and the tissue that retracts back down here is then closed. All right, moving on to eyelid malpositions, talking about ectropion, which is an outward turning of the eyelid margin. And you can have involutional ectropion, cicatricial, paralytic, or mechanical. Involutional ectropion is characterized by horizontal laxity, and if it's primarily medial, then you can do a medial spindle procedure, which is really just an excision of conjunctiva and lower lid retractors inferior to the inferior tarsal border, and then that's closed with these inverting sutures that bring the eyelid margin back to its normal position. If the involutional ectropion involves more of the lid than just the medial portion, then a lateral tarsal strip is indicated to create this strip of tarsus that's sutured to the periosteum of the orbital rim. And in some cases, reinsertion of the lower lid retractors. Paralytic ectropion is caused by deficits in or paralysis of the seventh cranial nerve, and it results in poor orbicularis function, which leads to poor blink and closure that then causes tearing and exposure problems. Temporarily, this can be treated with a tarsorrhaphy, but more permanent lower lid surgeries are indicated. And there's numerous ones that can be done, but it's important to support the lower lid in a paralytic ectropion. And one analogy that I like is that if you have a clothesline and a bowling ball is sitting in the middle of that clothesline, dragging it down, you can't just tack the clothesline back up, you have to remove the bowling ball. And the paralytic ectropion really has that bowling ball effect. And so you need to support the lower lid in some fashion, for example, with a mid-facelift. Doing a tarsal strip is not sufficient. A cicatricial ectropion can be caused by burns, trauma, or even actinic skin damage or chronic inflammation, such as rosacea or dermatitis. If it's possible to treat the underlying cause, sometimes that in and of itself may treat the ectropion. But if surgery is indicated, then you need to release or excise that scar tissue that's causing the traction, and then do some horizontal tightening either with a canthopexy or a tarsal strip, and finally lengthen the anterior lamella, usually with a full thickness skin graft. A mechanical ectropion is really just a mass weighing down the lid, and the treatment is to remove the offending mass. Moving on to entropion, which is inversion of the lid margin, there's congenital, acute spastic, involutional, and cicatricial. Acute spastic entropion typically follows some sort of ocular irritation or inflammation, and often there are mild involutional changes prior to that inflammation that then precipitate the problem. So the inflammation or irritation causes the sustained orbicularis contraction, which furthers the irritation and inflammation, which furthers the sustained orbicularis contraction, and this cycle ensues. It's important to treat both the underlying cause and the entropion because they feed off of each other. An involutional entropion is characterized by horizontal laxity, attenuation or disinsertion of the eyelid retractors, and an overriding preseptal orbicularis. Horizontal laxity can be tested. It's usually fairly obvious, but it can also be tested with the snapback test, in which you pull the lid away from the eye and it shows poor tone. And attenuation or disinsertion of the eyelid retractors can often be seen clinically. If you examine the patient, you notice a white line subconjunctivally several millimeters below the inferior tarsal border. You can actually see the retractors. It can also be characterized by a deep inferior fornix or ptosis of the lower lid, in which the lower lid is higher than usual because the retractors aren't pulling it down, or if there's little or no inferior movement of the lower lid on down gaze. And there are numerous surgical procedures to address entropion, but essentially they should address those three factors. Lastly, cicatricial entropion is characterized by shortening of the posterior lamella, and it has numerous etiologies, including autoimmune, such as cicatricial pemphigoid, inflammatory, infectious, surgical, or traumatic. If it's mild, a tarsal fracture procedure can be performed in which the tarsus is incised and a suture is placed full thickness that then rotates the margin outward. But if it's more severe, then it's important to lengthen the posterior lamella, typically with a graft of some sort. Just keeping in mind that caution should be exercised in patients who have active autoimmune disease, because scar tissue is likely to form and and the entropion will recur. So either those patients need to wait until the disease is not active, or they need to be on immunosuppressive medication perioperatively. Moving on to blepharotosis, there's myogenic, blepharotosis can be broken into sort of congenital and acquired, or myogenic, aponeurotic, neurogenic, mechanical, and traumatic. The most common cause of congenital blepharotosis is dysgenesis of the levator. Acquired myogenic causes include CPEO, myasthenia, oculopharyngeal dystrophy, and muscular dystrophy. The most common type of acquired blepharotosis is levator dehiscence, and congenital aponeurotic ptosis is pretty rare, which is failure of the levator aponeurosis to insert on the tarsus. Neurogenic blepharotosis, tends to have the same etiologies, whether it's congenital or acquired. It could be a third nerve palsy or a Horner syndrome. Another type of congenital neurogenic ptosis would be a Marcus gun jaw winking. And then mechanical ptosis is something weighing down the lid, and traumatic is precipitated by trauma. Important points in the examination of ptosis, certainly the vertical interpalpebral fissure height, but also the margin reflex distance, looking at the light reflex and its distance from the eyelid margin. Upper eyelid crease height can be important because it's often elevated in aponeurotic ptosis, whereas it can be absent in a patient with congenital ptosis. Levator function needs to be measured while fixating the brow so that the frontalis is not playing a role. I think lag ophthalmos is important to evaluate if surgery is being considered, because if there's lag ophthalmos before surgery, then that's really going to be an issue certainly after surgery. And looking at the lid position and down gaze can be important if you're dealing with a patient who may have a history of congenital ptosis, but it's not clear, because in congenital ptosis, the levator doesn't form normally, and as a consequence, it doesn't retract normally, which is why you have ptosis, but it also doesn't relax normally. And when it doesn't relax normally, the eyelid is actually higher in down gaze. So in a congenital ptosis patient, the affected lid is higher in down gaze than the normal lid. Ductions are also important for considering CPEO or myasthenia, for example, and pupil examination for patients with possible Horners. The treatment depends in large part upon the levator function. So external levator advancement works well in patients with a levator function even as low as 4 millimeters sometimes. But if it's worse than that, then frontalis suspension is really indicated. A Mueller's muscle resection can correct only about 2 to 3 millimeters of ptosis. It's a very quick and predictable surgery, but it can only correct a small amount of ptosis. Eyelid retraction etiologies include thyroid eye disease after recession of the vertical rectus muscles, remembering the interdependence of the capsulopalpebral head and fascia to the inferior oblique and inferior rectus muscles. Excessive skin excision and blepharoplasty can lead to eyelid retraction, as well as a contralateral ptosis just by virtue of Herring's law. And the treatment includes lubrication if it's mild, possible spontaneous resolution, or if it's more severe, surgery. Dermatochalasis and blepharochalasis are often used interchangeably, but they're different things. So dermatochalasis is redundancy of the eyelid skin, in contrast to blepharochalasis, which is really a syndrome of idiopathic episodes of edema of the eyelids, usually seen in younger patients, and over time the skin becomes thin and wrinkled. So how to summarize a talk about the eyelids in general, I like to think about what 2 or 3 things I would remember from any lecture. I think it's important to recall that basal cell carcinoma in the medial canthus is more deeply infiltrative, and it's important after excision to not treat any tearing and to talk about that with the patient preoperatively, that not to treat any tearing to avoid, for some time after surgery, to avoid seeding tumor cells. Squamous cell carcinoma invades nerves and is very dangerous when it does that to spread. Sebaceous adenocarcinoma, any suspicion of that requires a full thickness biopsy, and recall that it has multiple origins and map biopsies are indicated. And then recalling principles in eyelid reconstruction, replacing anterior and posterior lamella, a graft placed on a graft has a high likelihood of failure, maximize horizontal tension, minimize vertical tension.